Welcome friends, once again. Just a few minutes back we have discussion on a long case discussion, that is on pulmonary thromboembolism, and for that we have experts from St. Stephen's Hospital, as well as student DNB student from St. Stephen's Hospital, and we are also having Dr. Anurag Agarwal on behalf of National Board of Examination. And in this session basically we will discuss on these various small cases, but once again I would like to request all of you, please ask questions in our studio's telephone number, and toll-free number are also available. Wherever fax facility are available, you can ask question through fax, and this is the one opportunity that you can interact with experts and you can clear your doubts, whatever you have in your mind regarding that questions. And here the telephone number of our studio is very much visible. You can note down all these numbers, and here I would like to request Dr. Anurag Agarwal to process this discussion of short case on behalf of National Board of Examination. Dr. Anurag, please.
Good afternoon friends. The last session on long case was very beneficial and informative for the students, and I hope that this session on the short case will also be very helpful for the students, and I request Dr. Sethi and Dr. Nitin to take over and proceed with the short case discussion.
Thank you. Dr. Nitin, please.
You have to start the case.
Good afternoon. Now we proceed with the short case discussions. This is a can I have this guide for the case history, please? This a 34 years male patient presented to the casualty department with symptoms of occasional chest pain and difficulty in swallowing. This was a skygram which was taken for the patient and was referred to the Department of Radiology for further clarification.
This is a conventional skygram, the chest X-ray PA view. In this chest X-ray we can see that the trachea is in central. The trachea and its bifurcation appears in central. The chest, the pulmonary bilateral lung field, the right lung field appears normal. The left lung fields in the upper part, the upper left lung fields, the visualized portion show a opacity, a cystic type of opacity in the upper part with a thick margin. Then the mid zone appears normal, and again in the lower zone we see a inhomogeneous type of opacity. Regarding the diaphragm, the dome of the diaphragm appears normal. The mediastinal contours appears to be widened. The right border of the heart or the right margin of the mediastinum appears to be widened, and the imaged thoracic cage, the clavicles and the ribs appears grossly normal.
Yes, Jaipur, please. Yes, is there any questions? Jaipur, please. Is there? What is your questions, please?
I think the line has been disconnected.
Yeah, I think they're disconnected. Anyhow, please continue.
So on seeing this conventional skygram, we are having
from Jaipur.
Yes,
Just wanted to
please,
ask
Jaipur.
that this ECG pattern in the pulmonary thromboembolism appears like a right ventricular strain pattern. So in this case, we didn't find any change in the ECG pattern. So kindly explain this, please. And second one is, do we always see that pre-stenotic dilatation in the pulmonary artery?
Regarding your first question, can you repeat your first question, please, initially?
They just want to know regarding the ECG changes in the pulmonary thromboembolism. I think this is the exclusive session, but still, if you have explanation, you can discuss this issue.
Normally, the ECG changes in pulmonary embolism, generally they are normal. They could be, you could get arrhythmias, you could get features of infarction, ischemias in the cardiac region. But this gentleman, the case which we discussed, his ECG was normal. There were no changes in the ECG in this case, which I particularly remember. And regarding the second question of yours, which was the pre-stenotic dilatation, it is not mandatory. You may or may not have it. It is not in hand that you have an intraluminal pathology in the pulmonary artery, you will get a pre-stenotic dilatation. It is not mandatory, please.
We can continue our discussion.
Please continue with the short case.
So, seeing this conventional skygram, and keeping the history in mind that the patient has occasional chest pains and also difficulty in swallowing, the differential will be a pathology mainly in the mediastinum, mainly the posterior mediastinum where the esophagus is there, and some obstruction in the esophagus will lead to the dilatation of the mediastinum. So, and also since we are seeing radio opaque density, opacity in the cardiac region, this we can think of some like if there is an obstruction into the esophagus and leads to occasional in aspiration, that aspiration can also lead to the opacities into the lung fields. So the differential will be mainly the obstruction into the esophagus, like because of the achalasia, cardia, or some pathology in the esophagus.
See, again I'm repeating, whenever you see a skygram, you always follow the ABCD approach. See the airway, bones, cardiac, diaphragm. In this case, what we are seeing is this widening of the mediastinum. Alright. Now your next question in your mind should be, why should we get widening of the mediastinum? What are the conditions, structure which can cause widening of the mediastinum? Are you able to see the profile of the right heart border?
So the right heart border is seen.
What about the superior?
But the superior margin of the right heart border is not clearly seen in this.
Then, what else?
And also in the upper part region we are seeing a cystic type of lesion with a thick wall surrounding that.
No, whenever you see a widening of the mediastinum, what are the structures which can constitute the widening of the mediastinum? Normally which structures can constitute the widening of the mediastinum?
So the structures which are present in the mediastinum, like the which can lead to the widening, is from anterior to posterior. If we go, even anything enlargement of the ascending part of the aorta, first the thymus or thyroid swelling or retrosternal thyroid swelling can lead to the dilatation.
No, with pertaining to this case.
In this case, the cause could be mainly the cardiac enlargement, or could be a vascular cause like the ascending aorta or the descending aorta, or the esophageal origin for the mediastinal widening.
Okay. Whenever you see a cardiac cause, you said you see a cardiac cause. Whenever you see a cardiac pathology, you say cardiac. Always remember that cardiac, whatever, it's a hemodynamic changes. Our body is like a closed circuit. If one system is affected, certain parts of the other system will bear the brunt. Whenever you have a cardiac pathology, the lungs bear brunt with respect to the vascularity.
Sir.
Now if you see here, you are saying there's cardiomegaly, there's cardiac pathology. Which cardiac pathology you are thinking of?
So the cause for the widened mediastinum could be because of the atrial enlargement, the right atrial enlargement or the left atrial enlargement, and also sometimes the ventricle enlargement can lead to cardiomegaly.
When do you say left atrial enlargement?
In the left atrial enlargement, we will see a left atrial contour and also the double density which we see.
What do you mean by double density?
Double density is when the dilated left ventricle projects below the right ventricle density, the right atrial density, we find a double density. And in the double density, we can see the lower margin of the left atrium shadow of the lower margin of the left atrium within the shadow of the right atrium.
Whenever whenever you see a cardiac pathology, you say whether it is a right atrial pathology or a left atrial or right ventricular or left ventricular, apart from the change in the pulmonary vascularity, the contour of the heart itself can tell you whether it's a pulmonary pathology, which chamber pathology it is. A left atrial enlargement will cause widening of the subcranial angle. Alright?
Yes,
so if you see here the cranial angle is normal.
Then
So generally, and there is no double lens, so left atrial pathology is ruled out.
yes, sir.
For a right atrial pathology, if there is a right atrial pathology, what will happen? Can you comment on right atrial pathology on a frontal skygraph?
So in the right atrial pathology, there are two signs which help us. First, there will be the increased distance of the right heart border from the midline of the spine. Second thing, the distance between the diaphragm till the superior vena cava will be more than the distance of the superior vena cava above that. So even that.
What are you saying, please?
Sir, if we see the right heart margin, the distance from the diaphragm till the opening of the superior vena cava in the right atrium, the shadow, that distance is most of the time less than the distance of above the lung field distance above that.
Can you see the SVC shadow in this case?
In this case, we are not seeing
So
that.
how do you calculate that then? So whatever the way they have indirect evidence to say that whenever you have a right atrial pathology, normally the right heart margin occupies not more than 2 intercostal spaces, 2 or more than 2.5. If it occupies more than 2.5 to 3 intercostal spaces, some literature says 3 intercostal spaces, some say 2.5. But normally if the right heart border occupies more than 3 intercostal spaces, always keep in mind a pathology of a right atrium or a right ventricle. Always keep a pathology in mind of the cardiac. But it is not hard and fast rule, it is just an assumption. It may not be there. Alright? But in this case, there is no cardiac pathology as per se. Again, I told you, always look at all the structures which you can see on this thing. You are seeing a widened mediastinum. Can you comment on the funding gastric bubble?
Not clearly visual in this case.
Not clearly visualized in this case. Okay. Plus, if you see here, can there be mediastinal lymph nodes? Mediastinal lymph nodes can cause a pathology, abnormal widening of the mediastinum. Any normal structure which lies in the mediastinum can cause widening of the mediastinum. You could have lymph nodes which are enlarged. You could have vessels, pulmonary vascularity, which could be causing widening of the mediastinum. SSC shadow, which is on top, may cause. But in this case, SSC shadow is not there. You are just finding a linear opacity in the right upper zone, which is going supra-infraclavicular both. So, well defined. Whenever you see a linear opacity which is going above the clavicles and posterior down to the clavicles, what does it indicate? Is it a parenchymal pathology? First of all, you have to, whenever you see a pathology in the lung, you have to see whether it is parenchymal or extraparenchymal, that is pleural, extrapleural, parenchymal or mediastinal. So this linear opacity is parenchymal or extraparenchymal, that is pleural, or it is mediastinal.
So it appears to be it does not appear to be a parenchymal.
Why do you say this is not a parenchymal pathology?
Sir, because the direction in which this opacity is running, it's going.
Again, I repeat, whenever you see linear opacities in the lung, it has to be fissures or plate atelectasis. It's very or a loculated effusion in a fissure. Normally, we do not find any fissure here except for the ezygous fissure. Ezygous fissure, and ezygous fissure is not so thin. It's normally a thin, about a sub-centimeter thick linear opacity, curvy linear in the right upper zone. If there is a fusion there, then it could be thicker. But it's very unlikely there is no effusion. If you see the lateral chest wall is totally clear, the lateral coasting, the costodiaphragmatic recess is totally clear, the cardiomedicinal recess is totally clear. It's very unlikely that you have a isolated loculated correction in the ezygous fissure. Plus, you see, then what else could be a curvilinear opacity there? Apart, if it's not a fissure. If it is not a fissure, it is not a parenchymal pathology. It is not a pleural pathology. What else could cause a curvilinear opacity like this, accompanied with widening of the mediastinum?
So then the structures like esophagus, when it is obstructed lower down, and air fluid level, if we can see, then it can also appear in this place.
So this gives you a clue that you're finding a linear opacity which is going above the clavicles and below the clavicles, and plus accompanied with associated winding of the mediastinum. So whenever you have a winding of the mediastinal profile with a curvilinear opacity like this going up and up, so you could be a what could this be? This could be the
Air-filled lumen.
air-filled lumen of the dilated esophagus.
Yes,
All right. So what else you like now? With your, you could give an assumption that this could be a esophageal pathology, most likely a esophageal pathology causing winding of the mediastinum and appears to be dilated and thus resulting space winding of the mediastinum. So what you like to do is to confirm your assumption of wide pathological esophagus.
So the next thing could be a penetrated view, a penetrated PA view only, in which we can able to see through the mediastinum, and we could able to judge whether it is a cardiac origin or a posterior mediastinal origin. Otherwise, the next investigation could be a lateral scarogram, where we can find out whether the opacity, whether pathology is into the posterior mediastinum or into the middle or the anterior mediastinum.
So according to on the frontal scarogram, your assumption, this assumption is that this could be a esophageal pathology. What else could cause this? So esophagus lies in the posterior mediastinum, right?
Yes, sir.
Now, what else you like to do? Which investigation you like to do else after conventional scarograms?
I think what we are trying to get is, can you mention one investigation which will clinch your diagnosis now?
So then the barium study investigation will help us
That is
in
good.
this case.
That is good.
So this is your barium study. This is a limited sections of the barium swallow.
Sir, in this limited section we are seeing that this section is showing the lower part of the chest, because we are seeing part of the diaphragm shadow and then the upper part of the stomach, and we are seeing the GE junction in this given scarogram, the barium film. The lower part of the esophagus is diffusely dilated with circulation formation into the esophagus, and we can see that the very small amount of barium contrast is entering into the stomach through the GE junction, and depending upon this given scarogram, the lower part of the esophagus is pointing like a beak. This could be a bird beak appearance in this barium. And so the differentials on seeing this scarogram is some pathology of the lower part of the esophagus which is not allowing the contrast to reach into the stomach, like could be spasmodic contraction in the esophagus in the GE junction, or achalasia, cardia of that level.
Here I like to give emphasis on never come to a diagnosis initially. Always describe the entity, the disease entity in the radiological format. So here what you should say is you're finding a dilatation of the lower end of the esophagus accompanied with smooth narrowing of the lower end of the esophagus involving the GE junction. Whenever you have a smooth narrowing of the esophagus, whenever you have a hollow viscous pathology, always keep in mind, is it interluminal, is it extraluminal, is there any extrinsic impression, any intrinsic impression, any filling defect. So all these things should be kept in mind. So any mucosal irregularity. So if you see here, you are finding a narrowing of the lower end of the esophagus. Is there any mucosal irregularity here?
So in this case there is a smooth narrowing and with no mucosal abnormality.
No, smooth narrowing. Now is there any extrinsic impression on this?
So there is no soft tissue density to say if there is some extrinsic mass.
So you have ruled out extrinsic pathology. There is no extrinsic impression. There is no mucosal irregularity. So it's a smooth narrowing. Is there any filling defect here?
We are not seeing any filling defect.
So you have ruled out an interluminal filling defect also. All right. Is there any erosions there?
So it's in this given scarogram we cannot pinpoint any erosion in the.
Any erosions. Then look for any dilatation. Is there any dilatation?
So the lower part of the esophagus is dilated, diffusely.
There is no obstruction, or there is obstruction with dilatation of the lower end. There is obstruction there. So whenever you describe any hollow viscous pathology, always keep in mind. I always keep a mnemonic which I am telling to the viewers. Always keep a mnemonic of MIST in your back of your mind. MIST, M for mucosal irregularity, I for any intrinsic impression, S for any stricture or narrowing, E for any extrinsic impression, D for any defect, that is a filling defect. So whenever you have this type of approach in your mind, you will never miss, you will try to always come to a nearest possible diagnosis for the pathological entity as per se. Now if in this case, if you see there is no mucosal variety, it is a smooth narrowing of the lower end of the esophagus with no extrinsic or intrinsic impression, or neither any filling defect or erosion, except there is obstruction which is contributing to proximal dilatation. So now we know, first of all, you know the anatomical landmark, it is lower end of the esophagus. You know there is a narrowing there. So which is a pathology which you should think of in mind, which does not cause any mucosal irregularity, and there is no intrinsic or extrinsic impression, or neither any filling defect. So which type of pathology you keep in mind in that?
Excuse me, Dr. Rajiv, I just want to interrupt here. As like in previous session we have discussed to take any skygram, what are the precautions we take, until unless we take all those precautions, the skygram is not coming very clearly. Is there any precaution to be taken before the barium meal, or if it is not followed this precaution, what are the different of abnormalities we will encounter during our this?
A very nice, interesting question you asked. Generally, it is a common mistake by the, not a mistake, but you can say in a hurry, a radiologist always tries to give less emphasis on preliminary investigations. If he gets a referral for a barium swallow, he immediately puts the patient on the table, screens and gives a mouthful of barium and starts the study. It is always mandatory to take a plain X-ray of any pathology, any region. Always take a plain X-ray. The reason to take a plain X-ray is you have to exclude any foreign body, or any, supposing the patient has taken a lot of food, the food matter may interfere with the opacified contrast column of the barium, giving a spurious entity, a spurious reading, a spurious pathology intermixed with food particles. Always another important point is screening of the esophagus will also tell you about the lungs. So you can also tell about the lung entity, whether the patient has aspirated the food material. You will find pneumonitis picture, a consolidation. So you can get ancillary findings also with respect to your main focus of interest, that is barium swallow. Like you can see the lungs, they may be consolidation. When you are doing a barium swallow, your main focus of interest could be only on the opacified contrast column, because it gives you a better resolution and a black and white. So your main interest will be on the pathology as per se. But a preliminary investigation like a plain chest diagram will help you to say whether there is any complications pertaining to like pneumonitis, consolidation, effusion. That will tell you like. So always try to do a plain X-ray always.
Okay. Besides this,
can I add? If there is a contrast study involved in any part of the body, whether it's a barium study or a IVP with iodine contrasts, it's always nice to do this plain X-ray that Dr. Rajiv is mentioning. For another reason is what we call a scout film. It helps the radiographers to set the correct factors, so that once your dye has been given or the contrast has been given, you are not meddling with contrast factors. So if your scout film had good radiological factors, you got a good contrast on your film there. Now you give the dye and you'll get excellent results. But you know, if your first one was underexposed or overexposed, you're going to mess up the whole investigation. So it's always nice to have a scout film to go back and refer to.
Yes.
So yeah, that's another advantage of that.
Yeah, I would like to know one more thing is, as like right now you told me like underexposed, overexposed, right? The voltage amount has to be the same, or for the like barium swallow as well as the same for the skygram. Is it the same, or there has to be some difference? What do you suggest?
There is slight amount of difference because you are giving a opacified column barium which can absorb more X-rays. So you have to slightly increase the penetration. When you increase the penetration, you increase the kV.
Okay.
So and whenever you say whiteness on the film, which is because of penetration, increase kV. Increase kV is I'm going to physics aspect of radiology.
Yeah.
We have kV and MA, the two parameters on which the X-rays are taken. kV and MA. Whenever you increase the kV, you will find whiteness in the film. Whenever you increase the MA, you will find darkness in the film. So you have to interplay between kV and MA in such a way that the resolution for the physician, radiologist is easy because he used to come for a bad film also he can interpret, but a physician or the surgeon who is going to interpret the film himself, in absence of radiologist, he like to see a very crystal clear pathological picture in front of him.
Thank you very much, Dr. Razi.
Sir, should we proceed? So, can I have this diagram on the, can I have the X-ray film on the monitor, please? So if you see here, there is no extensive impression, you are just seeing a narrowing, smooth narrowing. So which, along with dilatation of the esophagus, and if you see the funding region of the stomach looks to be normal. So which pathology of the esophagus will cause smooth narrowing of the lower end of the esophagus?
So the pathology which can lead to the smooth narrowing has to be a benign pathology and not a malignant one.
Very good.
Because, and so the amongst the benign pathology of the lower end of the esophagus, which is causing dilatation proximal to the obstruction, the first to come is the achalasia cardia.
Okay. What do you mean? What do you mean achalasia cardia?
Achalasia cardia is that the lower segment of the esophagus is constricted. It's not smoothly dilating with the peristalsis, and because of that there is obstruction at the lower end and leading to the proximal dilatation.
So achalasia is a loss of motor activity
Modality,
of the
yes,
lower end of the esophagus. And what is the cause of loss of motor activity is there is degeneration of the
the
myotic plexus of aerobic. It's a neurogenic cause in which the lower end of the esophagus fails to relax. The lower end of the esophagus fails to relax, and there is proximal dilatation. The point to be noted, if I have kept this case, is this patient with this type of pathology will come with history of dysphagia, but there may not be any weight loss. And dysphagia for these type of pathology is progressive. That means they will be slowly slowly they will be difficulty in solving. They will be slowly. Gradually they will have severe difficulty, and then difficulty will be, for solving will be applicable to both solids and liquids. But they may not present with weight loss. That is the point to be noted. These patients with achalasia will not come with history of weight loss, but generally other causes dysphagia, where the patient cannot take food, they come with history of weight loss. But in this case the weight loss may not be there, and the reason for that is these type of patients are still able to take small amounts of meal by changing their body positions. By changing the body positions, they can gulp in small amounts of meat. Now the point here which I am trying to lay is, other pathological entities of the esophagus can also cause narrowing of the lower end of the esophagus. Like if the patient has got peptic ulcer disease, there may be reflux of the acid from the lower end of the from the stomach into the lower end of the esophagus, causing peptic stricture. But in a peptic stricture you will find irregularities of the lower end of the lumen. Plus you will find irregularities, and the patient will give you history of heartburns. Now another condition which can cause similar picture of achalasia could be a Chagas disease. Okay, what is Chagas disease?
So Chagas disease is a trypanosomal parasitic infection.
It is a protozoal infection which again causes narrowing of the lower end of the esophagus, and it is very tough to differentiate radiologically between Chagas and a true achalasia cardia. In both the conditions, the presentation on radiology will be similar, and you have to rely on the clinical parameters and the paraclinical parameters like lab investigations for confirmation of the protozoal infection. Generally, it is more common in the South America regions, right? Africa. Lastly, I like to say, whenever in a complicated scleroderma, again you could have narrowing of the lower end of the esophagus. What happens in complicated scleroderma? There is patulous of the low esophagus sphincter is very patulous. As a result, there is reflux of some amount of contents from the acid contents from the stomach through the patulous lower esophagus sphincter. In scleroderma, you have a lower esophagus sphincter which is patulous, and with the reflux of acid contents through the lower esophagus sphincter, they may become stricture in the later stages, causing narrowing of the esophagus. So a complicated scleroderma will also have dilatation of the proximal end with narrowing of the lower end of the esophagus, and that is not because of loss of motor activity, but because of reflux of the acid contents through the patulous lower esophagus sphincter.
Yeah, Dr. Rajiv, here I would like to ask one thing. Suppose in our constant situation the barium is not available, so but we have to reach the diagnosis. So right oblique or left oblique view is going to help this type of things?
No, the point is, whenever you say oblique, the role of oblique is to see anterior and posteriorly, like lateral only, plus give you a para-regional relationship. Any oblique can be done, but generally it has been taken into consideration whichever part of the area you're interested in, that should be closer to the film. So if you are interested in the, like I'm interested in the posterior medicinal pathology, so I'll like to keep a posterior portion of that region closer to the film. So any oblique can be done, medial right oblique or lateral oblique, no, nothing. But an esophagus being a posterior this thing, so I like to do a posterior oblique film because it will be closer to the film and it will give a better picture. But you can take any oblique, that is not the criteria.
Okay.
And lastly, can I have this? Can I have this slide, please? Now, if you see here, now again going back to conventional skygraph, that dilatation of the mediastinum attributed to widening of the mediastinum attributed to dilatation of the esophagus because of lower and narrowing of the lower end, and this spurious curvilinear opacity was the wall of the dilated esophagus with the air in the esophagus which was superimposed on the lung, because this is a one-dimensional film, not a two-dimensional. We are just seeing a PA view. We are just seeing a PA view. It is not a three-dimensional. So in this, the air of the esophagus being overlapped onto the lung parenchyma, giving a spurious picture of a spurious cavity in the right lung field. But that has been cleared by the barium swallow. So in total, if you go retrospectively, you find this was the wall of the dilated esophagus, and that was the air in the esophagus. This is the dilated esophagus, which is filled with fluid, and the reason for that was the narrowing of the lower end of the esophagus.
Here,
this
Dr.
has been
Dr.
given a very
sorry
fancy name. I'm just finishing it. This has been given a very fancy name called bird beak appearance, which is like coined like, can you see, like a bird's beak? There's dilatation, that is the head of the bird, that is the neck of the bird, that is the dilatation, the beak is the narrowing, and that is your stomach. So this is called a bird's beak appearance.
Yeah,
see that?
Wonderful.
That is dilatation, that is your beak, that is the head. So it's called the bird's beak appearance.
Yeah. Dr. Rajiv, in the first skygram diagram,
Yes, sir.
Here you said in the upper part,
Sorry.
there is a air in esophagus, so only the border is seeing.
Yeah.
And by the lower side, you can you said that it may be the like esophagus filled with water or some other thing. So is it like this where means if it is achalasia cardia, is there lower side may be filled with some food or
it could be filled with food material.
Food material,
Yeah.
which is giving like contrast white appearance,
Very
and
true.
upper side it is filled with air and it is giving the translucent. So things are like this.
Yeah, you're absolutely right. It is a mixed density. It's a mixed density. Normally, this column of what happened is when this skygram was taken, this patient may not have consumed meals. He might have become fasting, or he might have had meals early in the thing. There may be a 6-hour interval. The food residual material, which may be in the cervicothoracic portion of the esophagus, it may have gone down, because in achalasia, it is loss of motor activity in the lower end of the esophagus, not in the upper end. Upper end, the peristalsis still be there. There will be peristalsis, and the bolus of food will be going gradually descending down. But the pathology irony is that the lower end of the esophagus is not showing peristalsis because of loss of motor activity. So as a result, there is dilatation here, and in here, which has been, that's the normal swallowed air.
After seeing the barium picture, we have reached the diagnosis of achalasia cardia. So is the student supposed to give a differential diagnosis at this stage, or he should dogmatically comment upon, no, this is achalasia cardia and it cannot be anything else?
No, he should always first give a differential diagnosis. He should also, my top differential could be this, but I like to keep the following further differentials. Like, peptic stricture could be by second differentials, or a complicated scleroderma. But scleroderma should not be kept in mind, because scleroderma is a very rare entity, not seen in common day-to-day practice. But peptic stricture is common in day-to-day practice, where you see patients come with history of GERD, that is gastroesophageal reflux disease, resulting in narrowing of the lower end of the esophagus, falling peptic stricture, and that can also attribute to this. So always keep in mind a possibility of peptic stricture when you give a diagnosis of achalasia. But in peptic stricture, the patient will not give you history of dysphagia as per se. He'll give you history of not difficulty swallowing as per se. He'll give you history of heartburns. That's why I always lay emphasis to my students that clinical history is very, very utmost importance in the diagnosis of any radiological investigations. So that's why in the first slide which I always gave, I said the patient has come with history of difficulty swallowing. So that was my clue that my top differential could be achalasia. If I had said that patient had difficulty of heartburn, then I thought of peptic stricture as my top differential. But with difficulty of swallowing, I thought that achalasia cardia is my top differentials, but I like to keep peptic stricture as my second differential.
And differential diagnosis should be relevant to the case.
Very true. It should not be abstract differential like you are discussing a case of cardiac or a gastric and you go to nervous system. Should not be like that.
So the basic conclusion of this discussion is jumping any like skygram or any barium solo. First, they should aware about this history,
very
which
important.
give you the proper direction and for the investigation, which investigation we should go and what could be the best investigation. Just for the wasting, taking this also is not a good decision. So before jumping, we should take proper history and if other like supplementary like physical examination also necessary.
Coming to the history, my second case is also lays emphasis on a history where we were totally taken by surprise that a patient had come with history of only pain in the lower limbs, and how we ventured around the case. That is my next case, which I am going to show you.
Okay. Can I go back
Yes.
to that? I think if a student really wants to shine in the exams, having reached the diagnosis of achalasia, I think he can just go that one step further and say that the sequelae of this would have been a pneumonia or a lung abscess, and I would look for those in my chest X-ray. That I think would really bring him out of the ordinary category.
Like complications of
Yeah.
achalasia are aspirations, pneumonitis. So you like to see the complications. That's why I like to have a look at the chest diagram. What sir said, that look for any pneumonitis or lung abscess also.
So it is basically that saying, na, your eyes cannot see what
the
your mind
does not
doesn't know. So
Right.
until unless we are very clear in our basic concept,
Right.
what are the complications, what are the other compressing structure, really the things cannot be visible in our
That's why they say the clinical presentation of a patient is one of the blessed to the doctor, that he gives lot of clues that comes from the clinical presentation itself. Now, next case.
We have only 5 minutes. Huh?
Now this was a very interesting case which we got in our Nepal hospital. He was a 53 years old smoker who had come with history of chronic cough and presents with pain and swelling in the lower limbs. He had come to the orthopedics department in our hospital with history of pain and swelling in the lower limbs. And this history of smoking was asked following the complaints of pain and swelling in the lower limbs. And when the patient presented in the orthopedics department with pain and swelling in the lower limbs, so first thing they got was a X-ray of the lower limbs. So this was the X-ray which was taken of the lower limbs. So I would like my resident doctor to kindly comment on this X-ray.
This is the conventional skygram AP view of the lower limb, in which we are seeing the lower part of the tibia and fibula along with the along with the part of the ankle joint. We are seeing the part of the calcaneum in this, and which is they are the two skygram. One is showing the AP view, and other one is the lateral view. Seeing this conventional gram,
Just a minute, sorry. Before I'm interpreting you, I'm sorry. This skygram, this is this is of the right leg, which I'm showing you. This is of the right leg lateral view, and this is the left leg frontal view. Alright. He has pain and swelling. This patient had pain and swelling in both the limbs. Alright. Continue.
So on these conventional diagrams, we are seeing that the joint cavity, joint cavity has been maintained in the ankle joint. The distance between the lower part of the tibia and the dome of the talus, the distance has been maintained. Also, the distance between the tibiofibular joint cavity has been maintained. We are seeing some soft tissue density. If we are seeing the upper part of our scagram, where the tibia fibula and the surroundings area is there, we are seeing some soft tissue densities, added densities in the calf region.
Yeah. So we are running short of time, so I'll just try to give the important findings. Whenever you see a bone X-ray, any bone X-ray.
Dr. Rajiv, I think we'll discuss the case after the break, because right now our students already see this diagram, and because of constraint of time, right now we'll stop the session here, and next time after break we'll discuss the case in a full-fledged way.
Okay.
So I'd like to thanks to Dr. Rajiv, Dr. Nitin, as well as Dr. Vijender and Dr. Anurag also. And it is a very wonderful presentation of that achalasia cardia, which is very typical and very obvious. Everybody should know regarding this fact. And here the prominent diagnostic feature like Barium meal, all of the radiologists, they should know, as well as the precaution should be taken for this Barium meal, as well as other radiology. And the most important from this discussion, I feel, is we should not ignore at any point regarding the history as well as physical examination, which give us a lot of clue to identify the diagnosis. And here I would like to end the session, and I would like request to all the viewers to ask the questions regarding your confusion. If you want to know more, if you want to suggest many things regarding the session, how this session could be more beneficial to you, we are really seeking for your feedback, and we will meet after 15 minutes. Thank you very much.